you. Go ahead. Thank you. Nice to meet you. Hi.
Chloe Brown.
Chloe, nice to meet you. Well, you referred to me by your primary care doctor, Dr. Brewster.
Yes.
And how much, what do you know of why you're here, and how much has he told you?
Well, it was a routine, not an operation, but a examination, and he found something, a growth, and that's pretty much what it was.
Were you having any symptoms at the time?
No, not any real symptoms. Nothing. It was just discovered during a routine examination.
Okay. And you had your CAT scan, and did he discuss the results of the CAT scan with you?
No, he hasn't done that.
Okay. My field is oncology, surgical oncology, and he referred you to me because of what he found on CAT scan. And what he found on CAT scan was a large mass that most likely represents a tumor. It looks like what we call a sarcoma. Okay. Have you heard this at all?
I've heard of it, but not just in general terms. I'm not really sure what
all new to you?
It's all new to me. I'm not sure really what it is.
Well, I have a picture of your CAT scan, and I can kind of describe what we have, and sort of give you some information, and then you can sort of talk about your ideas and what you think you want to do. This is your CAT scan. Imagine you lying on your back. Your head would be towards the floor, and your feet would be coming up like this. So it's a cross section of you. This is part of your spine here. These are your kidneys. Okay. These are some major blood vessels here. It's inferior vena cava, which is one of the major blood vessels that goes to your heart. This large mass here is the tumor that we discovered in your CAT scan.
Wow.
Okay. It's what we call a sarcoma, intraperitoneal sarcoma. It's relatively uncommon. It's about 15% of tumors. The thing about your mass is that it's extremely large, and it's looks like it's abutting some of these major organs, including your kidney here and your inferior vena cava. Okay. The treatment options for this are generally surgical. There is not a lot of chemotherapeutic option or radiation options that do not involve surgery. Okay. This surgery would be a very large surgery. It's a very large mass, and because of its relation to all these organs and large blood vessels, there's a high likelihood of complications, bleeding, infections, and things that can lead to death potentially. So it's not a small operation. Okay. The problem with not doing anything is that because this is so large and so close to all these things, the chances that it's going to spread to other organs and spread to blood vessels and become metastatic is high. It doesn't look like at this point that there's any signs of metastasis. I'd have to look through all your records and make sure you had proper metastatic workup. But assuming that everything is, you have not had any metastasis, then I would recommend an operation for this to remove the tumor.
Okay. Now, are there any? You mentioned chemotherapy. Are there any other options available besides surgery? Chemotherapy, you said wasn't really a good idea, but are there any others?
Not for this type of tumor. This type of tumor generally needs to be resected. We do radiation as an adjuvant, generally after the operation. There's very little role for chemotherapy, not a lot of success. This generally has to be treated by resection. Okay.
By resection, you mean actually removing it?
Removing it, and we would have to remove most likely part of your kidney. Well, we would have to, once we get inside, we would have to remove all tumor. Okay, so the natural history of these tumors is that it invades locally into all the other structures. So if it's invading into your kidney, then we probably have to take your kidney. If it's invading into your inferior vena cava, that would entail a large resection of that vein and the repair.
Now, is this operation difficult to perform?
This is a very complicated operation. As I mentioned, it's a high-risk operation because of the size and because of all the adjacent structures.
Okay. Now, if I have this operation, could I be cured?
Well, the 5-year survival of these sarcomas that are not metastatic are somewhere between 55–65%, somewhere around there. These do tend to recur about 50% of the time as well. So we have a 50-50 chance of it recurring. What we would do is survey for that by serial CAT scans, looking for recurrence. So the bottom line would be that the 5-year survival of this would be somewhere between 55 and 65%.
Okay, that I would survive 5 years
Right.
with the surgery. Well, after the surgery, will I be able to run again? I'm kind of a jogger and I've run in marathons.
You're a very active person. Are you otherwise pretty healthy?
Yes. I didn't expect this, really. I've been taking blood pressure medication and also Viagra and aspirin, regimen of aspirin. But otherwise I've been healthy.
Ever have any chest pain? Shortness of breath?
Not especially.
No. Never had any heart disease that you know of? Heart problems, diabetes? Do you smoke? Have you ever smoked?
I smoked half a pack a day for just about all my life, since I was a teenager.
Are you still currently smoking?
Well, yes.
And you're running marathons at the same time?
Well, yes, but...
Well, it's obviously the fact that you smoke is not good, but if you're able to run marathons, then you must have at least some good genes. Sounds like your preoperative risk is low because you seem like a relatively healthy person. You have no known heart disease that we know of. We may do some preoperative risk assessment, have you see a cardiologist and get your heart checked out and see what they say, maybe a stress test, things like that. But assuming that you're relatively healthy, the recovery time would, it's generally an individualized thing. It's, like I said, a big surgery, so you would require a stay in the hospital, most likely at least a week if everything went well.
Will he be in the intensive care unit?
Initially, we would have him in the intensive care unit, and depending on how things were going, we'd probably move him out in a day, 2, 3 days. But it's hard to say because that's assuming that everything goes without any complications. It's hard.
Well, what could I expect during recovery, after going home?
After you go home, in terms of what?
Activity or pain, or just will I be able to go back to work?
What do you do for work?
Okay, I'm semi-retired. Okay, but will I be in bed or bedfast or for any length of time or anything?
Well, that's again, it's an individualized thing. It's most people after surgery are fatigued and tired, and certainly after a surgery like this, you'll be a little run down. It'll take some time to get back to your regular habits. It'll probably be a matter of weeks before you can really get back to your normal activity. 6 to 8 weeks before you do any heavy lifting or running for sure. But again, whether you'll be up doing your daily activities, that's again, it'll be sort of your own body's reaction to the surgery. Is average recovery time to normal daily activities after you get out of the hospital would be about
Well,
we would like to get you out of. What we would do is get you out of bed as soon as possible. Though we will push you, to get up out of bed and walk around. And that'll be, almost immediately after your operation. So we do encourage you to get out of bed and walk around and try to at least push yourself within your own limitations and your own reasonable limitations. The rest is sort of will be up to you and how you feel.
Will I be taking the same medications that I'm taking now?
What are you taking?
Okay, blood pressure medication, aspirin, and
you want blood pressure medication too?
I'm not sure. Is it in there?
It should be in his medical records. They did send a summary.
Okay, low pressure, aspirin. Yeah, you can continue your blood pressure medicine. In fact, we'll have you take that blood pressure medicine while you're in the hospital after your operation. The aspirin will probably hold for about a week or so. Are you taking the aspirin just for heart disease? For
Preventative.
Yes.
Yeah, and that will probably start a week or so afterwards.
When should he stop smoking? Should he stop smoking now?
Well, you should stop smoking.
Well, yeah, I guess.
You should stop smoking 20 years ago, 10 years ago, as soon as you can. The healthier you are, before this operation, the lower preoperative risk you have, the better chance you have of doing well in this operation. And there's good evidence that no matter how long you've been smoking, stopping smoking at any point in your life or during your smoking habit provides you with long-term benefit.
Could I still take Viagra?
I don't see why not. I don't think, I'd probably have to look that up. I don't think that there's any contraindication to taking Viagra for this.
Doctor, will he need
Let
blood?
me just clarify. You probably would also have to curtail your sexual activity initially, at least, just until you recover and your wound heals. And, so that will be a matter of weeks as well. I'm sorry.
Will he need blood transfusion?
There is a great chance that you probably need several blood transfusions during this. And again, because the tumor, a large tumor, these are all very vascularized tumors, and because of the juxtapositions of all these veins and arteries, not only do you have the inferior vena cava, you have large veins that are coming off of that. You have a large artery called the aorta, which is the main artery, has all your heart and feeds all your periphery. All that stuff is there. So if you do get into unexpected bleeding, even if you do get into expected bleeding, you most likely will receive a blood transfusion.
Can he donate his own blood, or can we donate?
People have done that. As far as the protocol and how we would go about doing that, we'd have to talk with the hospital. As far as risk of transfusion, I would say the risk of transfusions are relatively low. Your blood type is cross-matched, so we'll take a blood sample during your pre-admission testing, and we'll check your blood type to make sure that any blood you get, if it is not your own, which most people do not get transfused their own blood, they get transfused blood that's compatible with their own blood. The risks of infection are relatively low. There are occasional transfusion reactions. Those are generally mild. They can rarely be serious. Most serious complications from transfusions are if you receive multiple massive transfusions, which hopefully we won't need.
Now, I'd like the operation to take place as soon as possible.
Okay.
But would it help if I donated my own blood, or could I do that? Would there be enough recovery time?
Recovery time, meaning?
I mean, after the transfusion, undergo surgery, or after the donation of blood.
Oh, I see. The process of transfusing your own blood is, I think, takes a few weeks, anyways. We would take a blood count beforehand. You should, if you're a normal, healthy person, it shouldn't be too long before your cells regenerate and such. I would say, like as I said, the majority of our patients do receive blood and have no problems. What are your concerns
Oh, it just accents the seriousness of the operation, having blood transfusions.
I'm concerned about the screening, how well the blood is
Yeah.
screened. AIDS or hepatitis, can he get that?
The risk of AIDS and hepatitis are very, very low. I think some numbers are 1 in 2 million or something like that. Very, very low, very, very unlikely. Such that the benefits of blood transfusions far, far, far outweigh the risks. Those are generally not, those are real risks, but very, very rare. They'd be very uncommon to see. I have not seen that myself yet. Not that I know.
Okay. Will you be performing the operation, doctor?
I will be performing the operation. I'll probably have a senior partner with me as well to help out as well, but I will be the primary surgeon.
Have you done any of these surgeries before?
I have done several, but I also want my partner, who's more senior and experienced, to be there because he's done much more than I have. He's seen more of these.
What was the outcome of the other patients, if you don't mind me asking?
They did fine. One of them was in the hospital for about a week, and went home about a week and has done well. The other one has also done well. This is larger than either one of those, which is why I'm asking my partner to come by and help.
Has your partner done these
Yeah.
surgeries?
Done multiple of these. I don't know his number off the top of my head, but I know he's been doing this for a while. So
Can we meet with your
absolutely
partner also?
Sure, absolutely.
Ask some questions?
Sure.
We have grown children that live out of state. Should they come in for the surgery? Should they be here?
If they can, that would be nice. If that's what you would like.
Well, I'm sure they would want to be here.
Yeah, I think that would be good. Just for support.
And once he does go home, I work full-time. Will he need assistance at home? Would there be somebody who can come to the house, or should I arrange for my kids to be there for him? Will he be independent at all?
Well, what we would do, generally what we do is have physical therapists see you and evaluate you, occupational therapists evaluate you after you've gotten you through the acute phase and where things are starting to send you home. That's when we have physical therapists, occupational therapists to see your level of need and whether you can do basic things like walk upstairs or things like that. And they generally recommend, based on their observations, whether you would need any kind of help or home physical therapy. Sometimes they recommend inpatient rehab, which a lot of patients go through, which would be anywhere from a week, a couple of weeks, while you regain your strength. It's all kind of up in the air, and all those things do happen. I mean, generally somebody with your health, I suspect would do relatively well, and not have too many needs, but again, it's hard to say. But all that stuff will be taken care of. And we also have a social worker that works with us, and they are usually very good at assessing the help that you have at home if you're working full time. And if your kids are there, and we think that they will provide you with enough of what you would need, and we think that it would be within their means, and we would probably say that's okay. But we would assess the situation at the time. But the most important thing would be getting you through this operation safely and avoiding any complications.
Is this possibly hereditary, that my children could develop this someday? Should they be screened for that?
To be honest with you, there probably is a genetic component to this, as in most cancers.
There is, you said?
Probably is. I don't think we know all of the details of the genetics and whether we have proper screening tests for this.
Is this a very uncommon type of tumor?
It's not uncommon. It's not the most common. It's probably about 10 or 15% of all tumors. So it's not something that's not seen.
Okay.
Well, thank you.
If you, sounds like you do want to have the operation.
Yes, as soon as possible.
Okay, fine. Let me have you sign some forms since we have you here. Something. This is the consent for the procedure. operation is going to be resection of retroperitoneal mass. Let's see. Excuse me 1 second here. Go through this with you. Before the operation, we'll have you see the anesthesiologist, and like I said, probably have you see either a medicine doctor or a cardiologist, and just to see if they need to do any screening for you, some stress tests, echocardiograms, things like that.
And we do want to meet your partners also, if you can arrange for that at
Sure,
the same time.
no problem. So you can sign here. 305, 9 a.m. So the name of the operation is a resection of the retroperitoneal mass, which is a removal of this tumor. This consent form just broadly says that when there are no guarantees of any surgery, there are other alternatives, one of them being to do nothing, to live with this tumor, and that's always an option.
Well, it's not going to get any better, is it? It won't.
No.
It won't decrease in size over time.
You will require most likely, that will definitely require general anesthesia for this, and there are risks associated with anesthesia that are separate than the risk of surgery. The risks of surgery, as I mentioned, are infection, bleeding, renal failure, acute respiratory failure, massive transfusions, and even including death. Okay, and you have to understand that this is a real possibility from this operation. Okay, there's a real possibility that you need to take a kidney or other structures that are involved here. All this stuff is potentially possible. There is also the most likely possibility that you would require a blood transfusion. This does consent for blood products at the time, blood transfusions, which may or may not be your own blood. Again, it would be cross-matched blood, and screened blood, and the risks of those transfusions are very rare, very low. And that's the gist of this consent form. So you can read through this and ask me any questions, and when you're ready to sign right there.
Do you have any more questions?
No,
I think you answered.
Chloe, okay.
And this is a consent for the blood transfusion as well.
Okay.
All right.
Thank you.
Okay, so we'll have you meet with us a little bit later and set up a subsequent appointments and get you set up as soon as possible, okay? Nice to meet you, Ray. Nice to meet you.
See you again.
We'll see you later.
You'll have a pen.
Oh, yeah.
Sounds good. Listen, I just lost one of my peripheral IVs. You want me to put a central line in this guy? Because I don't have access to his arms. Okay, you got to put how much bleeding you got? Quite a bit. All right. Central lines in. How many units of type did you type across the form?
4 units.
All right, I'll call for a couple of units. You want me to transfuse? His blood pressure is 80 over 50, and we're starting to lose him now. His blood pressure is 40 systolic. Listen, somebody needs to do CPR. We're losing him. Giselle, can you do CPR, please? Institute ACLS protocol. Giving him some epi. And epi's in. 2 units of blood are in. He's about 90 over 40. Heart rate's about 120. His cardiac output is low. His index is low. CVP is 3. Okay, stop CPR. Okay, we got him back. He's got a blood pressure of 90 systolic. I'm giving him more blood. Alright. I'm losing him again. We're going to have to do CPR. I've got more volume going in. Epi's in. Okay, doctor, stop CPR. He's in V-tip. Let's defibrillate him. We just defibrillated him. I have V-tip. I have no blood pressure.
Keep going.
Alright, I have nothing. He's asystole. We're doing CPR. He's got, we've defibrillated him. He's got epi. I've been giving him epi every couple of minutes. I gave him a milligram atropine. Alright, we're doing CPR. Alright, I've gotten 4 units of blood in. I've sent out some coags. Stop CPR. I've lost him. I've lost him.
How long has it been?
He's got nothing, absolutely nothing. He's
Never
gonna,
regained those?
nope, never regained his vitals. Alright. 10:22. Call it. It's called 10:22.
We'll talk to this family. Brown.
Hi, that took a long time. Nobody came out to tell me anything.
I have some bad news for you. You had a serious complication. Your husband, during the end of the operation, got into some serious bleeding that we were not able to stop. He did lose his vitals, and we weren't able to bring him back. Unfortunately, he's died.
Oh no. Didn't you give him blood? Didn't you have blood to give him?
We gave him blood. We gave him all the fluids we could. We tried to stop the bleeding, but it was too much bleeding. And we did everything we possibly could, but we weren't able to bring him back.
I thought you had a special team to help you in there.
We
Didn't
did.
you tell me that you'd be prepared for this?
We did, and like we showed, the tumor itself was right on a major vein, and during the dissection of that tumor off the vein, there was a large hole in the vein that was left, and the bleeding was too fast and too much, and we just couldn't keep up with it.
Where
We
did the
tried
hole come
everything.
from cutting him or trying to remove the tumor?
It was all probably during that. The tumor itself is either eroded into the tumor and into the IVC, which is the main vein that we were talking about, and it was either eroded into there or during the dissection it was cut. Don't know for sure, but unfortunately we weren't able to save him.
How are you going to know for sure what killed him?
Your options are to do an autopsy if you like to find out exactly what happened.
Well, I want to know what happened.
Right. Okay. We can set that up for you. I think we would also like to find out exactly what happened, and so we can learn from this as well. I'm very sorry.
Did he have a heart attack?
His heart stopped.
Stop?
His heart stopped. Right. His heart stopped. And it was just from the severe blood loss.
Oh. What do I do now?
Well, you can stay here. There's a chaplain that we can call if you would like to discuss it, if that's what you would like to do. The operating room staff will clean your husband up, and you'll be able to view him shortly.
Oh, I don't know if I can do that.
Okay. Would you like me to call a chaplain for you?
I think that would be a great idea.
Okay.
And what about my kids? What am I going to tell them?
Yeah.
My daughter's getting married in 2 months, and her father won't be there. Oh, what do I do now? Maybe he shouldn't have had this operation. Maybe he would have lived longer, at least to see that.
I can't say for sure what happens. I'm very sorry.
All right, send
We
me the
have
chaplain.
Okay. We also have social workers available that you think might be of potential help to you or benefit to you, if you're ready to talk to them now or in the future.
I've never had to plan a funeral. I don't even know what to do.
Mm-hmm. We have support staff here that can help you along, but I think for right now, you should forget about the planning and just have a conversation with the chaplain. Just allow this information to sink in first, and then you can deal with the planning afterwards. And of course, I'll be available for any help that you may need.
Okay.
Okay.
Okay.